technology and continues to make advancements in it. And what we're seeing now, he recently published his 20-year follow-up that showed less than 1% revision. We published our TBI data as well, showing about a 1.26. Sorry, Terry, I thought we were better than you, but not. And then we had Rick Sasso published a 20-year paper on the Bryan disc. And then we have Todd Lanman, who is another landmark surgeon who has really pushed the envelope. Todd showed us that we can take down pseudoarthroses and do artificial disc. We can even take down fusions. So as we go into our 25th year, I think it's appropriate that we have these two great surgeons and speakers. So we're going to start out with Terry, and he'll give two cases, 15 minutes apiece, and then at 30 minutes after, we'll go to Todd. So Terry, thank you very much for staying up late. For those of you who don't know, it's almost 2 o'clock or 2 a.m. France time. So, but Terry's a night owl. He doesn't sleep.
One second. Okay. Here we are.
Perfect.
Okay, hello everybody. Thanks for your kind words. Yes, it's 25 years. The first case of the product we are using now has been operated on December 16, 1999. So we passed the 25 years 1 month ago. Here I will show two cases, how complex, or I will say mistakes done, and how we can save the problem. The first one is a normal case with L5S1 disc and discopathy and the disc herniation, never operated, a very young man, 31 years old. And we have we see the disc L4, L5 is black, but at that moment, it's an old case. It's in 2002. I had not the temptation to perform the two levels. Modic 0. You see the motion pre-op. You see on the right, it's not a very, very extreme parameters, because 46 degrees of incidence, it's more than the normal, but not so bad, and 38 of sacral slope. I think it's in the normality of the low deviations. That's a pre-op. The pre-op motion, as you can see, is stiff. On the left, you see that you have 52 degrees in lordosis, in extension, and 60 on the pelvic floor. Those two numbers are always to be looked, because this one shows retraction of the psoas, and this one shows if there is a retraction of the hamstrings. So it's very important. But okay, all was fine. There is no reason to have a problem here. And we operate on the 25 February, 25th of February 2002, and the patient at that moment, it was a rule as to stay 1 week. And so the control was made just before they go out of the hospital, so after 6 days of surgery. And as you can see, after 6 days, you have an impaction, implant in kyphosis. Okay, very bad placement, but also impaction. So that means that there is immediate subsidence. Is it a fracture during the introduction? Is it a bone weak? Probably both, not expected. What to do in this case? Because you see, the ODI was around 40, VAS was 8, and after the surgery, he had no pain, or almost no more. He's not very tempted to be reoperated on. He has a sedentary work. And so the patients agrees or push for an active survey. If there is I have no pain. Is there a risk? Immediately not, but the risk of the result is to be very poor, or perhaps the pain will come back. Okay, we will see at that moment. So I follow the guy. 2 years after, you see it's still there. You see there is no modification in his pelvic parameters. The motion in L5S1 in the bending test is not good, but for the disc above, it's working well. Okay, that is a pre-op table of the motion you have already seen, and that is 2 years. So you see there is not a lot of modification. It's almost the same than before. Okay, this doesn't move so well, but the patient is not painful, so he's satisfied. I am not, but the patient is. At 5 years, you see the ODI evolution 16, 8, 6, the VAS 0, 0. No, it's a great clinical result with a very bad image. We have a progress in the motion, a little bit, 62 in extension, 62 here, 79 of L1 race compared to the 56 before. Okay, it's in progress. So we can classify this patient in the, I will say, bad result, but no complication and acceptable. Even you cannot be satisfied about that. That is his motion at 10 years. He moves well. It's complex to understand, but the patient is moving well. Now I have not measured the X-rays because it's too short. It has not been done in my unit. But now the sacral slope grows to 80, and he has a good motion. He's still with good result, and we follow him. And now he's 47 years old and 16 years after the surgery. And you see the quality of the clinical result. It's impressive. He has no degradation about the clinical results, no migration, no osteoporosis, no subsidence. It's enough. It's stable. Doesn't work there. Okay, the motion is still there after 16 years. 65 degrees of sacral, excuse me, 65 degrees of sacral slope, a good range of motion, not terrific, 85 degrees of L1 race. And what we can say is the choice was not so bad not to operate on, not to reoperate. And it's so sometimes the politics of wait and see, if there is no risk and if the clinical result is good.
Terry, it's
But
interesting. Go ahead. I'm sorry.
it's not so bad. Even what it was in 2002. So what would I do today?
Is this
Perhaps
a triumph or defeat?
I'd say it's a triumph.
it's a it's a
Clinical triumph.
no, it's a Pyrrhus battle.
It's a
Pyrrhus.
Yeah, but how many
defeat,
patients do we all have that have X-rays that look less than what we would like, but have clinical results that the patients are very happy? And I think I think that's a success. I mean, I forgot which South African colleague of mine said, treat the man, not the scan.
Yeah, we don't operate X-rays. We operate patients.
Well, and
uh,
I was going to make the comment when we started the Charité study, and remember that was a smooth end plate that had no bony ingrowth. Amazing that we even put them in. I can't believe that we did, but we would have this kind of picture was not unusual, Terry, and we, for the I don't know why we never went back in. We just said, okay, we'll just leave it be, see how they do. And we have similar cases just like this where it doesn't look great, but patient is doing terrific. One of my worst charities almost looked like it had perched facets. The guy was 15 years out. He was running, 5, 10 miles a day. And then what doomed him was he got an empyema and seeded that disc at 15 years out. So we had to take it out because, it was infected. But it was a horrible looking x-ray. Didn't show anybody, didn't show Jack, didn't show Scott, but the guy was doing perfect.
Yeah, I have a case also. I remember my presentation of Jack Ziegler was saying that is my best case, a guy with a boat. And he has an infection on one level in one direction and another one in the other one. I have exactly the same. I never reoperated him. Okay, he has I would say a small moving fusion, not a very great arthroplasty motion.
But a painless one.
But if you balance that with a revision, the risk of a revision, especially on those cases on 2 levels, the risk of revision is one thing. The capacity we have to fix the problem and to do it better is another
So,
thing.
so let me ask a question. So
Yeah.
say you have a patient that has an x-ray like this, and we're all different, and they have kind of low grade back achy 2, maybe 3 out of 10 back pain. Are you going to recommend a revision for 2 or 3 out of 10 back pain and a wonky looking x-ray? What do you think? I mean, we've got France, we've got LA, I think we've got Gold Coast, Australia on here. We've got Dallas. What do we think?
I would not, a 2 out of 3 pain, typically here, I said, this is a quality of life call for you as the patient. I said, you need to come in here and tell me you want this pain better, and bringing anybody down from a 2 to 0 is challenging if they've had prior surgeries and certainly revision. There's always, I mean, I've had 7 back surgeries, so I live around a 1. Sometimes I get up to a 3. I take a couple of Advil, I'm fine. And I can live in that range. Most people, I think, could, but I always leave it to the patient on that. Especially as Thierry mentioned, there's no real risk here. It's an ugly X-ray, and the patients want a pretty X-ray, and I don't blame them. But I've had this happen as well, and I just sit there and watch them, and they do fine typically, and most of them I've explanted some. And I do have a question, Thierry, about explantation later, but about another time. But
Hey, Terry, before you go on to the next case, I do have a quick question. Were you doing bone density back then? And how would you tell the people that are watching to try to avoid this? I know it's hard to say because we've had these many situations.
We have typically in young male like that, 30 years old, sportmen, we don't perform the DEXA because it's we should, but it's complex in the preparation, and so we do it for women after 50 years old, men after 60. Before we don't do it because the ratio of questions, I would say, it's 1/4,000. So to perform an exam that costs a lot for 1 on 1,000, if I prefer to have a look and to have some symptoms that attract me, the aspect on the CTs, the density on the CT, and things like that, before to go to the DEXA systematically in young people.
Terry,
in addition to applauding your restraint on not jumping to do surgery, we should not forget that L4-5, these days, many people would recommend a 2-level disc replacement based on the MRI. And
Right.
this case proves that not necessary. You addressed the symptomatic level, it became asymptomatic, and
Okay.
L4-5 looks okay.
yeah,
And I have not the time to do it, but when I am analyzing my 1 level, I have 800 cases of 1 level operated with long term. And I am catching all the black disc, initial black disc L4, L5. And how many has been reoperated on? 2, 3, It's a 1.8%. So choose on almost 1,000 is 1.8%.
That's
Very
pretty
good.
good.
Let me
Terry,
ask you a
before you go to the next
Yeah.
case, I just want to say something for the audience out there. We do bone densities on every patient, at least Jack and I do. We see a number of young people actually have osteopenia. And I think it's because the younger generation doesn't spend a whole lot of time outside getting sun and making their nice vitamin D3 in their skin. But anyway, so Terry, why don't you go on to your next case? That was great.
Let me ask you a real quick question. Really quick, Terry. Have you seen, because that was a 0-11 degree, the old 0-11. Have you
Yeah.
seen more subsidence with the 11 degree versus the 6 at L5S1?
100 times. 100 times more.
I agree, because I had a
The
11
11
degree.
degree, that's why we have created the 8 and 3, because the 11 degrees in the superior plate is a very good, I would say, tool to dig inside of the plate.
Right. Okay. I just wanted to
Just a
bring.
couple. Can you guys hear me?
Hey,
Yes.
Matthew.
Yeah,
Yes.
good to
Hey,
see you
Matt.
from Australia. So I'm not sure I can shout that far across the big pond, but I actually am in Vale at the moment. Just witnessed an interesting result of an election that took place last year. Anyway, never mind about this. This is not uncommon. You've got to do the bone densities in anyone over 40. Often if it's a curved end plate, ProDis is the best prosthesis. Get the superior end plate right back on that inferior border. You can see that one wasn't, and I've made the same mistake. The next thing is one level disc replacement load shares with the next level, so you can do it if it's symptomatic disc, and that's why discography is useful. The next point I would make is that X-rays mean nothing. You take away the disc that's painful, doesn't matter if it subsides, it fuses or replaces. We see the people are pretty happy. So I think that's just testimony to a good result and just how versatile disc replacement is in this situation. If you did a fusion there, got a subsidence, you wouldn't have the same result, in my opinion.
You're right.
Yeah, and the problem is, if you revise it, especially perhaps not this case, but often your capacity to put a disc in good condition is complex, and so perhaps it will you will revise it for a fusion at the end. If you are in the incapacity to redo a disc, so you revise and you open the patient to get a fusion. It's just so don't do it, because here you have a small motion and no risk, so there is no reason to change it.
I'm not doing this to the panel, but I'm just whoever's in the background listening. If you revise this from the front, you're just going to create problems. It's a young male, so he's going to get retrograde ejaculation.
So
If you look at his vessel separation, he has no neurological compromise. He has no vascular compromise. You are doing an operation to satisfy yourself. And so in that case, if he did have symptoms, it's a in situ pedicle screw posterior fusion. And with our modern techniques with guidance systems, robotics, you can do a Wiltsy type approach, get a lovely fusion, and that's it. That's how to revise that. Just leave the prosthesis. It's done its job. As I said, for a prosthesis only for vascular and neurological compromise. And 30 years down the line, that is not the case here.
Can I ask a
Yeah.
question? Let me ask a
And
question.
we got to go on,
For
Scott. We got to go on.
No, I get it, but this is like something we need to talk about. Besides discography, for multi-level dark discs on MRI, is there any other way to determine which disc is symptomatic other than discography?
Nocia scan.
Those you scan.
Right. Even Matt agrees with that. Thank you, Matt.
That pleasure.
And how is that
found
proven?
various results with Nociscan, but yeah, I've used it.
Yeah. Where's the data on validating Nociscan versus SPECT CT versus modic changes? Where's the data on that?
No
Well,
one's done any comparison studies at all on all those modalities. SPECT scan is just going to give you a reflection of what the bone is doing. That's all. Nothing more, nothing less.
And the
and
Nocia
to see
scan
if-
gives you a biochemical signature of the
Yes.
disc.
Exactly.
Normal disc has
That's going to be the future.
signature. Right. All right, Terry.
okay, the second case, it's a male of 49. Before he was a rugby player, southwest of France. He has a stenosis in 3 and 4. He has a disc operated 2 times in L4 and 5, 92 and 2000. He has one surgery in 96 on the A5S1. We have Modic on the 5-1. We have a stenosis in L3 and 4. So it's an indication of 3 levels. The only thing you see that I put visible is this big spurs on L5S1. The big spurs on L5S1 because this you have to remember this one also has been operated a long time ago, 20 years, more than 20 years ago. And so with the technology of that time, the quality of the fluoroscopy of that time. And if you look to this, okay, he has good parameters. This one also is not very exceptional. He has a good mobility in pre-op. We cannot always my table here. You see, okay, it's not very good, but he has a good balance. That means that he has a not privilege of retraction on psoas or on hamstrings. Okay, but he has 44 degrees of L1 raise, so his handicap in motion is very high. So indication of 3 levels. Okay, that's the control in post-op. I have been betrayed by the big osteophyte in L5S1, and I have not centered my disc. Don't ask me why. If I knew, probably I would have fixed that before. Probably pushed by the osteophyte and the bad quality of the fluoroscopy. So, and this one you cannot let it like that because he has a hyperalgic sciatica on the right side. That means he has a direct compression of the nerves in S1. So I have to revise it. The question is, here we don't operate the image, we operate a patient suffering. The question is, if he had no sciatica, what would we do? Probably I would change it, but just because I think it's too much far away. The risk is a secondary complication, so it's too much far away. There is also one reason we don't like to let patients go out with such an X-ray, because each time he will see a radiologist or show his X-ray, you are not painful on the right, because you should be painful, because you are not painful, or you should. Especially the radiologist who hates the surgeons. So when they can find something to split on the surgeon works, they always use it. Okay. So I have to revise it, and I have done it. Okay. Oh, okay. Why I have not done that the first time, don't ask me. But okay.
I was just going to say, Terry, 25 years ago, a young surgeon named Thierry Marnay once put his arm around my shoulders and he said, "Your post-op X-ray is your business card."
I say that, yes, that's true. Yeah, post-op X-ray is your business card, absolutely. So the question is, will that change the result?
Did the revision surgery get rid of the sciatica?
Yeah, absolutely, immediately.
Okay.
For sciatica. So you have the motion here at 18 months. L1 raise 79. We have, you see, we have always this balance between the lordosis in extension and the pelvic floor. That is those two are linked, and it's only the muscular and ligament balance that makes it, because there is no connection between the extension of the lumbar spine and the flexion of the pelvis. But probably it's because of the retraction of the muscles, or I would say the elasticity of the muscles. What is interesting here is we start by 79 of L1 race, 18 months. You see his evolution, fantastic he was 84 in pre-op on the ODI, one of the maximum I never got. He has 10 in he had 10 in the VAS in lumbar in low back pain and 10 in pre-op in sciatica. After that, at 3 months, 0.4 and 0.000, we could follow him long term, as usual. And you see the evolution. Now he has a complete flexion of the spine. It took him several years. It took him several years to be at that level of flexion. It's very impressive. But now you have a pelvic form of 56, and you see here the inflection is 84, the pelvic flexion. The extension is 75, always the same, but we have a progressive release with the time. Probably he has made a lot of rehabilitation, but you see that the motion at 18 months is not always the picture you will get at 5 years. So it's very interesting. It's very interesting to look at it like that first, because the revision has not damaged the patient and your result. In the first case, not to revise has not damaged your result, but here the revision has not damaged. And the second point is, it takes time to recover the motion. Especially this guy who had 3 surgeries between 92 to 2000. In 8 years, he had 3 surgeries in his spine. So he has a big scar posterior that probably it takes time to be a little bit released by the massage and the re-education. But you see, with a good patient, who is no more sportsman, but he has been a sportsman, you have a good result with time in the motion. And it's very interesting to look to the long-term motion is very interesting. Unfortunately, I have a majority of 24-month motion. Sometimes I have, in my publication, I have 20 years, but it's not all the cases, because patients, when they are doing, the fact is, and I will close on that. Each time I see a patient, long time after, 16 years, 20 years, typically they have good results, but they don't come back. Those who are not missing the appointments at 3 or 4 or 5 years are not the best results. It's the opposite of the FDA or control, who says a patient who is lost is a bad result. No. A patient who is lost is often a very good result.
They're not on social media complaining.
That's right. What was
Absolutely.
What was the time interval, Terry, between the first and revision surgery?
2 days, 3 days.
Okay. Yeah.
Terry,
Terry,
when he woke up, he had a pain.
I see.
Terry, did you notice that immediately with the C-arm, when you first implanted it, and you waited to see how he did, or?
No, I have not seen it.
You had,
I completely missed the implantation. I think if I remember well, I think my screw or my key wire was in place. But I have done something that with the big osteophyte what was pushing me out, I have completely my vision has been completely disrupted by that. It's important. So even when you are who are the guy who has performed the most important number, that doesn't prevent you to make a very big mistake that you will kill your assistant if he was doing that.
Thierry, when he had the right leg sciatica, I assume you did some imaging. And when you did revise the implant, did you go back and resect the posterior annulus across the whole of the disc in order to relieve? Did you just rely?
I think I have made a complete release on the right side. I think I I have even taken off or opened the foramen, and because the poor nerve needs more, even more place than it should have before, because he has some edema, and you need to make some room for the nerve to breathe a little bit in those situations.
Correctly
What
right.
do you do?
That's
What
it.
do you do routinely, Matt? Do you resect or release or both?
Well, I think it's whatever restores the posterior height, and I think it's an important point to bring up tonight is that for people that are, within the first 1,000 disc replacements, you've got to feel comfortable about getting back to the posterior annulus and resecting it in order to get a balanced disc space. And so you have to take down what you have to do. We do it in ACDF every single day, and if you're not, you should. And so you should be doing it in the posterior spine. Now, if you distract up and your posterior annulus gets that 8, 9, 10 millimeters, then leave it alone. But that's where the pain generators are. And often some of those cases where you resect that posterior annulus, not only do you get the best back pain reduction, but you get that really good leg pain reduction as well. So I think it's important for everyone who is a little bit of a novice or trying to understand how disc replacement is successful. The secret lies in getting back to that posterior annulus and then what you do with it.
You have to get a balanced release and good parallel distraction,
Correct.
one way or the other.
The only time I leave the posterior ligaments intact, if I'm topping off, for example, an L3 to S1 fusion, putting a disc at 2-3, I'll do a release, but I won't do a total resection because I've had people get hypermobile over that segment with a total resection of the PLL.
Actually, that's a very good point, Todd, because in hybrids, you've got to be careful with that.
Yeah.
Yeah.
However, what is sure is the 2 or 3 cases I had an hyperalgic sciatica when the patient wakes up. I immediately, I don't, if it was not like that before the surgery, I immediately put it in the condition to get a radiculogram with a CT and things like that, and reoperate immediately, because a few hours of compression have no after effects sometimes. But if you let 24 hours, you are not sure that you will recover and not have a permanent pain after that with fibrosis and things like that. So I think it's one of the rare cases that I would push the team to work till midnight. I will not let the patient more than a few hours with that type of compression, because the sciatica is hyperalgic like that. Sure, you have a problem. So you have to find it. It may be a small piece of bone that you have broken and pushing in the canal. It may be it's always bone, and it's never a piece of disc. A piece of disc is painful, but not so hard. Only a piece of bone of a metal compression makes such a pain, such acute pain. Okay.
So if the disc prosthesis is well positioned and they have the post-op sciatica and you image them and you don't see anything, then what do you do?
I go to the church.
Yeah. I mean, sometimes at L5S1, if your assistant is not paying attention, you're not paying attention. We use the Wiley retractors. You can jam the L5 root over the sacroiliac. I've had one in a young gal. Thank God it came back. But as Thierry said, if they come in if they come the post-op area with the new neurologic deficit, you have to image them immediately and find out what's there.
If I compare, if you remember, we had this discussion on the post-op sciatica in Phoenix.
Yep.
Time. And my conclusion was sometimes for the small sciatica post-op was RIP, RIP, rest in peace. Don't touch it. Don't try to reoperate if it is because in my first generation, when I had I would say very bad cases and very bad release, because I didn't know how to perform the release well, and the local condition of access were not what we have today. I had a bad release, and it took sometimes a few months. I had, I would say, 30 or 40% of patients with, I would say, small posterior sciatica pain in post-op that was disappearing in 6 months.
You're
And
going to
it was
bring him in serum
my
inside.
release was not good. My release was not good at that moment. And I think
Right.
now we have this. You see this question we had in Phoenix. We don't ask it anymore. So that means that we have less and less sciatica pain in post-op, and probably it's because of the influence of those who have pushed to make a complete release and like Jack to open the posterolateral corners and things like that. It's very important to and it's it's the same. Well, it's the same. When you perform your first total hip replacement, you don't want to resect all the capsula. You don't want to resect all the synovial. You want just to have enough place to put your prosthesis, and you have bad, I would say, not so good results. And so one day you make a complete release and it's better. Here is the same. At the beginning, we were pushing the disc, even in the remaining disc in the posterior part, and we were not pushing the disc far away. And now we take off all the disc, we see the ligament, we resect it or not, we open the posterolateral corner, we go in the foramen to take off the spurs and the osteophytes. We make our job now better, and that's why we have less sciatica in post-op than we had at the beginning.
And
That's-
it's exactly analogous to doing cervical arthroplasty. I think a lot of us weren't doing adequate decompressions. But Terry, those are great points. I think we could talk about this forever, but Todd is waiting patiently. Terry, you're more than welcome to stay up. I know you're already up. We'd love hearing your comment, but if you want to go away and go to sleep, that's fine.
Oh, it's good, it's good. I cannot miss Todd. No.
Okay. All right,
Thank you,
Todd,
Terry.
take it away.
Terry, thank you. All right. Okay, so let's show this. Here we go. All right, so I'm going to show some cervical defeat and a failure here. I think I'll start with this defeat. And this was a gentleman, he's 52-year-old. He came from Arizona out here to Los Angeles. It ended up with a 4-level cervical. At first, I did many years ago at C3445, I did Prestige LP disc, which has a translational core for those of you.
Let me know when to flick, Sandra. Want to shut, go off?
Well, back to rest for like.
Okay.
Hey,
Okay.
Matt,
Oh,
you
Oh.
go ahead, Todd.
That's okay. So Prestige LP is on the top. That's a translational core. And then later I did the 2 lower levels, which are symptomatic. But he had, as you can see here, at C23, he's got some arthritic facets back then, and he had this upper facet pain. And he was in Arizona, and he went ahead and he had multiple rhizotomies. I wasn't really aware of this. I thought he was getting facet blocks, but he had 7 total rhizotomies, which to me means the pain doctor is trying to make money, not really treat the patient. But as this went on, I did CT scans, and you can see the total destruction here of the C3-4 facets and the gapping in 2-3 and so forth. And he was translating over the C3-4 disc, and I was concerned about the C4-5 as well. So I thought I would come in and fuse him from 2, 3, 4 to 5, explanting. I use that plate as just a retention plate, really, for when I flipped him to go in the back of the neck. And he was improved, and he was okay for, I forgot how long, a year or 2. And he called me up and he just said, "Hey, I'm starting to get more neck pain again." So I got this film and I was like, well, okay, the lateral on the left looks okay. The lateral bending, he's a bit hypermobile on the bottom, and that's okay. And then I'm like, oh, his extension film looks great. Look at that flexion film. And I almost passed out. I was like, you need to get in your car and put a neck collar on and drive out here as fast as you can. He had 0 neurologic deficit, only mild neck pain with this x-ray. So here, this is a fail, and obviously he's parked completely over the seat. My fellow is here, so parked over the C5/6 disc, and he reduces beautifully in extension. And so I said, come on out, and we need to revise this because this is going to be an issue neurologically, perhaps. So I extended down to T1 and fused him here. And he's doing okay. I mean, he still has pain. It's minimal, but he still, lives in pain. He doesn't move his neck anymore, which is why he came to see me. So this is my fail case, and that's what I did about it. I think that one of the points I wanted to make, well, several, but when you have a patient with an arthroplasty with a translational core, it's probably, or it seems to be potentially risky with multiple, for example, if they have facet pain, to get multiple rhizotomies because they destroy the facet capsule. They actually destroy some of the bone lines, and then they obtain hypermobility on those segments. Now here on the hypermobility over C5/6, now the ProDisc is much more fixed core. I usually use ProDisc lower, and I might use translational or softer core disc upper. But I suppose part of this issue would have been when I did his posterior fusion, I may have disrupted some of the capsule. I'm going to be very careful about that with an arthroplasty and fun. But you can see he's totally ruptured his facet capsules at C5/6 here posteriorly. I mean, and the interspinous ligaments are completely ruptured. So he's still moving relatively well at 6/7, but I just said, I'm sorry, I'm removing everything because no discs seem to work in you. And he's doing okay now. And so I think that's an interesting case.
Why'd you revise the lowest disc? That seemed to be working okay.
I was concerned. I was scared. I was scared because
Todd, I don't blame you.
He's hypermobile over that. I mean, what if he?
No, I mean, I get it. I mean, because the worst thing that could happen is you do everything, leave the bottom one, and the bottom one gets hypermobile also. So,
Right.
I mean, I get it.
So that's kind of what he's been doing and coming down. And I just, look, I think it's safer for us in your case just to do that. I mean, I have many bottom off and top off cases that are 3-level fusions with bottom off ProDisc at C6/7, and they're fine, and so forth. So I thought that was interesting. I don't know what other questions or comments you guys might.
Sitting here, I'm pretty sure since we have the benefit of a French surgeon here, this is a great case of Jean-Martin Charcot. It's a Charcot arthropathy. This denervation was too good. It destroyed the segmental nerves. It destroyed the joints. Those first two x-rays that you showed show a classic Charcot arthropathy to my end. This is not just a mechanical thing. The denervation was too good. What do you think, Thierry? Was that a Charcot arthropathy?
It's exactly what you see in we had in the 70s, 80s great rhizolysis people in France who performing that permanently, and we described a lot of instability with a lot of hypermotion after that, even some. And it was a great discussion about instability and is it unstable, destabilized. Today we don't see it anymore because there is less and less and less rhizolysis. And I think it's exactly that. It's you create an arthropathy or you create the condition of an elastopathy. It's almost the same. If it is not the you add the elastopathy and the nerves.
And Todd, you said he had like 7
rhizotomies. You destroy the
rhizotomies?
nerves and you destroy the capsula.
Yeah, but he also probably had ischemic changes. You know, he had heat and probably devascularized the facet capsule and they necrosed.
Yeah.
So there's probably mechanical and a neurogenic component to
absolutely.
to that
It's
level.
both.
It's both.
Yeah, it's both, like elastopathy associated with neurologic, and you see that absolutely in Charcot-Marie tooth disease.
Right.
And Todd, you said he had what, 7 rhizotomies?
7 rhizotomies. I didn't even know he did that. He was like, well, I feel a little bit better after I do these. And I was obviously not too happy about that, but
Yeah, I think Jack's right. I think that just destroyed the capsules of the facets.
But
yeah,
it's it's not very well known the consequence of the rhizolysis. Everybody thinks it's okay. It's no risk, no problem, easy. No. You see, if the multiplication of that can create a very severe disease,
Yeah, but
especially when they are in the hands of the people who don't control that, like pain managers or things like that. It's uh, it's a danger.
yeah, but for the majority of patients who get this once or twice in their life, we don't see this issue. So I think this is just the extreme thermal injuries.
that's what I sort of felt as well. All right, well, I'll move on to the Triumph. We have 12 minutes here. So this one's rather short, actually. I was just not sure what to do with her. She's a 57-year-old woman, came from Florida, and she wanted discs in her low back and her neck, which I did both the same day. But I was really concerned here, giving her C3-4, where she had never had surgery. And that C3-4 appears autofused in flexion. And you can see, her mobility there on the flexion x-rays is rather dramatic, and the utter collapse below of all the discs. So she had neck pain, she had radiculopathy, headaches constantly, and so forth. And I said, look, you might need a fusion and correction up top. I said, but I can do artificial discs in your lower segments at 4, 5, 5, 6, and 6, 7. But I wanted to investigate her cervical 3-4 a little further with CT scanning, which on the right, you see, it looks as though she's bridged here. Now there is CT averaging, but here on the left on that extension, it looks like there's a little gap there, but she was not mobile there when I did explore it. And this CT sort of, and there were several other slices through there that looked fully bridged. So I said, well, you're fused here. I said that we may have to deal with in the future if your neck pain persists because of a flexion deformity there at C3-4. So I went on to perform the arthroplasty here. You have the neutral here. And what I did with the ProDisc SK is I made sure I put the implant, and you can see how anterior they are on the left film in the neutral position. I tried to set the center of rotation as far forward as possible, even further forward than midline, to help her correct a bit in extension. And you can see on the extension film, she corrects nicely, but you see that each implant is rather forward, intentionally putting the COR forward to engage her a little bit more in extension, and then the flexion film is there. And I literally just did a Zoom call with her 2 weeks ago, and she was crying. She was so happy. She has no headaches, no neck pain, no arm pain, and just feels utterly amazing. And so I thought, wow, this is interesting, because I wanted to make the 2 points that even though there is some upper cervical deformity and a horribly degenerative neck, because often people are just looking for a small dark disc with a bulge, that you can really restore the height and restore the motion, like you said, doing a good decompression, a good release, releasing the uncinate spurs and so forth. And then thinking about, that she's going to tend to want to flex forward. So how do I put the implants and use them to my advantage here? And so if you set the center rotation forward, they want to sit more in neutral position, or if anything, in her case, puts her slightly extended. And she feels great like this, which kind of amazed me. So I thought I would show that as a win, as a triumph. Although I was concerned about how she would do, and I thought I might have to do something up at the top, but I do not at this point.
Hey, Todd, what was the time frame
the
of this
question I
picture?
have, the question I have is, okay, so I mean, we all see these people, and for cervical arthroplasty, we've kind of all been trained in radiculopathy and myelopathy, and we all know that there are certain patients that with just axial pain and spondylosis and deformity will do better. How do you advise those patients? I have a hard time saying when they say, okay, what's the chance that I'm going to be like really, really better? I don't know how to answer that question because we don't have a ton of data on exactly this pathology, which I think I agree with you. This is a freaking home run, even without dealing with 3-4, which is a way messed up level. How do you, proactively tell these patients like, okay, this is what I think is going to happen? Or do you just say, look, it's just a 50-50. I have no idea. We're going to do this and we'll see what happens.
Well, I told her this. I said, look, I think the bulk of your pain generators are your degenerative discs. You're auto-fused at C3-4, or it seems you have no motion. So that is not likely a neck pain generator for you. I told her, and I said, I think doing the artificial disc, and we all alluded to this in the lumbar, like you can pretty much, like you can have a subsided disc, they don't have pain. And I sometimes I say to the fellows, I say, you could throw a bolt in the disc space and they're better. It's like you just get something in there. Besides, remember the old furniture and balls? We used to do all kinds of things. If you get that implant in there, I said, I think you have about a 70-80% chance of the reduction. I said, I don't know about C3-4 if we're ever gonna have to do anything if that's factoring into your pain. But her CT scan, I didn't get into that on a pre-op. You can see her facets at these degenerative segments were quite healthy, which is what we commonly see when you have severe degenerative collapse. Those facets are usually relatively healthy, not always, but usually, because the disc isn't really moving much, the facets aren't wearing away. And so when you come in and you reopen and remobilize the space, I felt she had a good confidence interval of having significant enough improvement to proceed. Although I didn't give her my usual 90+% that I would.
How'd you come up with 70-80%? I just don't know how to tell my patients with this pathology and axial pain if I do multi-level disc replacements. I tell them it's a flip of the coin. I tell them 50-50.
I think it's higher than that, Scott. I mean, in my experience, I do a lot of these degenerative multi-level cases where they're bone on bone, 3-4 levels, and you put them in and they're 90% better. The other patient with the facet arthroplasty and the rhizotomies, no, but for the most part, I get such a great result with multi-level arthroplasty, even in the severely degenerative segments, that I'm confident to give them a much higher rating than 50.
Well, and I happen to agree with you, but I try to set the bar really low because I just don't know, and there's not a ton of data out there. But I happen to agree with you that the results are better than 50-50, which is what I tell my patients. But I mean, like you said, this is a home run. I mean, and it's not something that's kind of in the mainstream of either fusion or arthroplasty, axial pain, multi-level disease. But those of us have a lot of experience like you do, Todd. We know that it is better than 50. I happen to set the expectations lower just because I don't have the data to support it.
No, that's
Matt Gornett published, and you were part of that, Todd, the Prestige LP long-term follow-up, and he had a subsegment of patients that just had neck pain, and those patients did just as well. Now, I don't think you can tell them they have a 90+%, but I think it's not unreasonable to say you have an 80+%, for symptomatic degenerative disc disease. And, especially in a somebody like this where you have 3 levels, one that's almost fused, and I don't think I would lay the crepe that much, Scott, say 50-50, because we in the lumbar spine. Terry, you gonna say something?
No, I have a question for Todd. Todd is an artist of dysarthrodesis. Why you have not treated the kyphosis C3, C4 by medium resection and the re-extension of this to correct the global kyphosis? Because your result is, I would say, damaged a little bit by this kyphosis in the upper part of the spine. If you had made your adrenal osteotomy and put a cage in extension, would you think that we would get a better result?
I didn't think that it would change her result that much because she was really not mobilized there and not moving here. So at C34. So I didn't elect to do that. I mean, I told her we may have to do that. I don't know that that level, and I did not think that level was really symptomatic in her because this has been ongoing at C34 for, I mean, that didn't happen overnight. That's been going on 10, 15, 20 years, who knows? And so I didn't think that was her pain segment and generator. And as she's 57, I know the degenerative disc disease in her would be much more likely to be her generator and much more progressive. So I didn't feel the need, Terry, but I did think about, I even thought about trying to cut it and do a 7 millimeter.
Yeah, and to make an extension.
And give
You
her
have
more
a-
extension
you
there.
have a
I got
more.
close to doing that, but I just said, you know, I think you're going to do well with this, and she has, and so I left it alone. But yes, I thought about doing that a lot.
How many years out is she, Todd?
Just a one.
Just one. Okay.
One. Yeah, I just did her 1 year. Yeah.
So Terry, you would have done the osteotomy at 3-4?
Not yes. If Todd is with me in the room.
Hey, Todd, what I'd worry about a little bit is because she doesn't live her life in extension, even in neutral, she's springing her interspinous ligaments and her facet capsule. So, you know, I just worry that some of her pain, if it wasn't coming from the posterior elements, may do that. And that's the only place that arthroplasty may not have been the best thing for her if you wind up having to do a posterior fusion. But, you know, you're Captain Kirk on the Starship Enterprise, you know, you're kind of going where man's not gone
I've never
before.
gone
So,
before.
yeah, so let's, you know, we'll all learn. At least, you know, you're honest about it, you're showing it to us, and you're keeping track of your patients. So that's why you're part of the family.
Thank you.
And that's why we had you for the first one, you and Terry.
That's right. Thank you.
Yeah, all stars.
Right.
Quick thing by Randy Davis from Baltimore, who is, by the way, one of our All Access Pass recipients, together with Richard Emanuel, Thomas Riley, and Luis Cartararo. So many thanks to you for your support. But he asks, how do you get this funded? So 2 levels is the max. We fight with that. Is it self-pay? Do you have any tips or tricks to share that you can get this insurance approved?
Yeah, well, insurance is never going to approve it, and so they usually just pay for the discs, and you know,
It's LA, you can do that.
You can get the insurance to pay for a 2-level and have the patient buy a 3rd disc and put it in. You can have the patient buy, you know, you can get a 3-level discectomy decompression, you know, approved, and then the patient buys the disc. You know, you're looking at what about 14,000 for 3 discs. So yes, it's a challenge for patients who don't have the money, and we do have a foundation also at our surgery center where we take some indigent, you know, people can't afford it, and the foundation actually buys the extra implants, and we put them in. So that's a few of the ways we do that.
Yeah, and it's actually infuriating when we do the peer-to-peer and they're, you know, just parroting back the indication of the insurance companies, but yet we as the surgeons have developed the indications, and it's over a 20-year period. So, I mean, we all do peer-to-peers every day, and I just sort of shake my head. You know, they
Yeah,
parrot
it's
back.
maddening. It's absolutely maddening because they're happy to approve an occiput to, you know, T5 fusion in a heartbeat, no problem. And you want to do 3 discs, it's like, oh my God, what are you talking about? You're out of your mind. And it works. I think, Terry, you told me before, you know, the 3-level lumbars do better than the 2 that do better than the 1s. I mean, they just do great. I just did a 3-level lumbar today. I mean, it's just hideous what insurance companies do, and it's not right, and it's harmful to the patients because sometimes they force people to have fusions because a lot of the other surgeons out there, besides us and maybe some others, really aren't going to push that and really aren't going to think out of the box or how do we get this done. And then they end up just fusing the patient because that's all insurance will pay for. I've heard, how many times have you all heard patients come in and say, well, they're just going to approve a fusion, so I just had a fusion, and then they have another disc degeneration. And I think that's just criminal.
It is, Todd, and
Great
especially
lead-in.
as we see that the long-term survival rate of these discs is now exceeding 20 years in both Terry's follow-up, our follow-up, Matt's follow-up. and with very, very low revision rate. So when I see a 30-year-old and they tell me they've been told they need a fusion and the insurance only pay for it, I say, don't have it, just wait. If you can wait,
That's right.
don't have it.
Correct.
Great lead into our next arthroplasty conference that Jens and I have been talking about for a couple months, which is going to deal with the insurance industry and how they've been so much tougher on arthroplasty than anything else in spine. So thank you for that lead in.
Well, if Bobby Kennedy gets approved, he's my patient, he's a friend of mine.
We've already invited him to
Oh.
speak at our next arthroplasty conference, but no response yet.
Well, I'll.
If you can give me, if you can give me a better contact info, I will reach out to him tomorrow.
Scott, it's time for Mama. Make America mobile again. How do you like it?
Yes.
Absolutely.
Yeah.
Hey,
And
I think
here's-
Terry just signed off, so I want to thank Terry for staying up late for us.
Right.
But-
Thank you,
And
Terry.
thank you,
Terry.
Todd.
All right,
And here's-
guys.
Let me put a commercial
great
in
session.
also next month, excuse me, in March 12th. We're going to do part 2 of our session this evening with a spine surgeon, but with the 3 Viscogliosi brothers. So if you haven't seen part 1, it's available on YouTube. It's fascinating history of arthroplasty from the business standpoint. And we're going to continue with them on March 12th. So hopefully see you there as
Fantastic.
well.
February
All right. Well, thank you, everybody. Thank you, Todd. We really
Excellent.
appreciate it.
Thank you, guys. You
Everybody
did great.
take care. Remember that you're all access pass to Seattle Science Foundation CME. Thank you, Jens. Thank you, Corey. And
Yes,
Dr.
thanks, Jens.
Dyer,
Good
very
night,
nice
Corey.
job.
Thank you, all of you.
All right.
Good
Fantastic.
night, Terry. Good morning, Terry.
Good night, Terry. Go to sleep.
Mama.
All right. All right.
Bye,
Bye-bye.
Jens.
Bye, Jens.
Take care, Jens.
Bye, Jens. Yeah.